everyone. Thank you for joining the MDA Medical Education team as we host our Grand Rounds webinar, How Are Registries Informing Neuromuscular Disease? In today's webinar, attendees will recognize the benefits of patient participation in NMD-specific registries and observational studies. Attendees will improve their knowledge about published findings and recommendations from NMD natural history studies. Attendees will leverage resources to help patients enroll in registries and observational studies. And I'm excited to introduce our panelists, Dr. Dara Heitzman, Dr. Michael Isfert, Dr. Matthew Burford, and Dr. Paul Maida.
Thank you so much. And thank you for MDA for the opportunity to present about the National ALS Registry in this important webinar. So my name is Paul Maida. I'm the PI of the National ALS Registry. So we've been in existence for almost 15 years now. We're a multifaceted research platform. We like to say we do a lot more than just count ALS cases. We have a biorepository, which is very robust. It's a national ALS biorepository. We go coast to coast to collect samples from patients completely free. We look at the epidemiology of ALS, for example, the incidence, that is number of new cases, prevalence, those who are living with disease, mortality of ALS. Work with partner organizations such as MDA to kind of go ahead and get the message out about joining the registry and the importance of joining a research program like the National ALS Registry. We also collect survey data. These survey data are probably some of the most robust in the world. We have over 120,000 completed surveys from over 20,000 ALS patients who've actually enrolled since October 10 when we first launched. And these survey data encompass where did you work, where did you live, potential exposures as well. So they're pretty robust data which are collected by us. And we also publish these data as well. We also have something called a research notification mechanism or system, where we actually have drug companies or institutions come to us for support when it comes to augmenting their clinical trials or their epidemiological studies, and I'll mention that later in my slides as well. We'll go ahead and connect patients directly with these upcoming trials. We also fund research, and so we fund grants to higher academic institutions looking at the risk factors and the etiology of ALS. Next slide, please. So this kind of just goes back to how we were actually formed. There was actually a concerted push back in the early 2000s from patients to have their own ALS registry. So they actually petitioned Congress, and back in 2008, Congress actually passed Public Law 110-373, which is the ALS Registry Act itself, which actually created us. We launched back on October 2010, and then from there, the purposes are certainly multifold, looking at the epidemiology of ALS, like I mentioned, demographics of disease, who actually gets ALS, and then why are they getting ALS, which certainly is very important. Like I mentioned, we have over 21,000 individuals who self-enrolled. It's probably one of the largest collections of ALS data in the world. If you look at all the other ALS registries which are out there, whether it's in Europe or other parts of the world. Like I mentioned, we're one of the oldest ALS research programs in the US. I like to say we are of, by, and for those living with ALS. Next slide, please. So when it comes to looking at ALS, we want to figure out how many cases of ALS are there. And so we've actually published some recent studies looking at the state level findings as well as national findings. The state level findings, these are both first when it comes to prevalence and incidence. And what we actually found was prevalence has been higher in certain states as well. So right now, the lowest is Hawaii at 2.6 per 100,000, and the highest was Vermont at 7.8 per 100,000. This is just a small caveat and just a brief. All these publications are available on our website at cdc.gov/ALS to go ahead and get the full text of these actual publications. But what we found was certainly also a gradient as well. So the prevalence and incidence also was very similar in the Midwestern states. So Vermont actually had the highest incidence as well as the highest prevalence. And we actually found a gradient going from north to south, which also observed on other diseases such as MS as well, multiple sclerosis. So we also found cases higher in the northern latitudes when compared to the southern latitudes. And like I said, this is just a very, very brief overview of the state level findings. I would certainly encourage you to read more about them on our website. And then go to the national ALS findings, national level findings of prevalence. We actually did a projection, and currently in 2025, we have just over 34,000 cases of those who are living with ALS currently. And this number actually will be increasing. So by 2030, we're going to estimate close to over 36,000 ALS cases. And it's going to be increasing because as the population ages, the prevalence is going to be increasing. So that's where our justification, our hypothesis is coming in regarding the ALS prevalence increasing in the U.S. itself. Next slide, please. This right here is the gradient I mentioned earlier, where you can see the state prevalence and incidence. And you can see actually from a north to south where we do see a higher level of cases of both incidence and prevalence in the northern states, and it just kind of decreases as you go lower. It doesn't mean that there are cases we are missing, which I am sure we are missing in the southern states such as Texas, Florida, and so forth, because you do have snowbirds who actually come from different parts of the country who may come to Florida for winter as well. But in general, what we have seen is a higher prevalence of an incidence of ALS in the northern part of the U.S. Next slide, please. I mentioned risk factor surveys. So like I said, we do a lot more than just count ALS cases. And these risk factor surveys are self-administered. And this really helps us as researchers. And all our data are also available for other researchers to request as well. And we ask those living with ALS, where do they work? Because we know certain occupations have a higher risk of ALS than other occupations. Were you in the military? That certainly is a very important question, because those who actually serve are twice the risk of getting ALS than those who've not served, and we're not sure exactly why that is. And that's certainly important for us to kind of figure out that information. Physical activity, smoking, drinking, those are also risk factors for ALS too. Where did you live? Certainly, potentially where you live. Were you on well water or sewer or city water? That certainly by itself could be very important, because sometimes exposures do happen, and if you're living downwind from, let's say, a potential factory which is potentially spewing toxicants and so forth, you potentially could be exposed. So we want to figure out where you live and ask you where you live. And so forth. Traumatic brain injuries is also very important as well. We know TBIs themselves appear to be a risk for ALS, as well as other diseases too. We also ask about disease progression. How fast is your disease progressing? Is it fast or slow? It's an ALS FRS survey that we actually ask ALS patients themselves. And we also have another survey. Like I mentioned, we have 18 surveys, so this is just a small snapshot of those surveys themselves. We also ask patients what they think caused their ALS and so forth. And a lot of these findings we've already published on as well. And so we're always collecting new data. We're also taking these data and also cross-matching them as well with other data sets too, to see exactly what we're seeing across the board. Next slide, please. Looking at the biorepository, I mentioned, so we have a national ALS biorepository, which is very robust. We collect patients from coast to coast. It's nationally representative, meaning to say it's not just coming from a specific location itself. It's user-friendly. We actually come to the patients' homes themselves to go ahead and collect their blood. If you don't want your blood collected, we can send you a saliva kit in the mail. You can go ahead and do the saliva kit. Saliva is not as valuable as blood. Blood is much more valuable. Saliva has limitations. And then from here, what we want to do is we want to figure out, exactly the genetics of ALS, the biomarkers of ALS, disease progression. As of right now, there is no specific blood test for ALS like there are for other diseases out there that you can actually say, hey, this blood test actually is elevated for a particular disease, so therefore this person has this. At this time, there is no specific diagnostic test. There are some other tests out there, such as neurofilament light chain and so forth, which are out there, which certainly can be helpful for disease progression. But there is no early onset blood test for ALS at this time to simply say, hey, hold on for a second, maybe you potentially have something going on here, and let's go ahead and explore it further. So we want to go ahead and use these samples for, like I mentioned, genetics, disease progression, biomarkers, as well as exposures as well. Next slide, please. So continuing with the what I just mentioned, like I said, for example, we also genotype all our ALS patients as well. So we see exactly what sort of gene they may have, whether it's SOD1, C9, North72, and so forth. I mentioned earlier regarding the biomarkers. So we want to see exactly, if are certain drugs working or not working. And then, like I said, we want a blood test. We want some sort of diagnostic test which could potentially catch ALS early on. I think that would be very, very important. And then environmental factors. We want to see in those samples we have, are there potential elevated, heavy metals, lead, arsenic, and others, or are there other organic pollutants? And organic pollutants are called persistent typically because they don't really break down in the environment. So pesticides, insecticides, and these particular toxicants, are they in the blood? Are they in the tissue and so forth? And we want to see exactly if there's a correlation between, those amounts of pesticides, insecticides, and so forth in one's blood, and see if that kind of correlates with an elevated risk of ALS or not. Next slide, please. I mentioned research. So I mentioned clinical trials earlier. So we actually have a system that we actually developed, and the system by itself allows patients to opt in for information about clinical trials. And so what we do is we'll go in there and we'll get an application, let's say from a drug company, whether it's Biogen or MT Pharma or a host of other companies who want to augment their clinical trial. We'll read their application and we'll go ahead and send in information to the patients themselves, and they themselves will go ahead and contact the drug company for the particular clinical trial itself. We've actually have done this for over 80 institutions, and from our data itself, we've actually estimated to having actually enrolled literally thousands of patients for clinical trials and epidemiological studies. It's a complete free service for drug companies as well as academic institutions to augment their studies and their clinical trials. And this is just the Healy platform trial is one of the ones we actually help to recruit for as well. So it's a very robust system for us to kind of, have those individuals who are looking for clinical trials to kind of help them match a clinical trial and so forth. Next slide, please. I mentioned research, so we actually fund quite a bit of research. To date, we have 28 research studies we funded. We're looking to fund 2 more this fall, so there'll be a close to 30 institutions we've actually helped to fund. And so every year we do a funding opportunity announcement to kind of go ahead and solicit applicants to come in and apply for research. These grants typically range from 300 to 500,000 per year, and they're 30-year grants. And so we certainly encourage researchers to come and go ahead and apply to us. And at the end of the day, what this research does is helps us trying to figure out what causes ALS and the risk factors associated with ALS. Next slide, please. So these are some of the areas we've actually funded. So looking at cyanobacteria, harmful algal blooms, that certainly has been really important to see exactly, is exposure to cyanobacteria potentially linked to ALS, pesticides, pollutants. We're also looking at the human virome. So we're looking at the viruses and seeing is there a potential common virus associated with ALS. Genetics, we want to see exactly why certain populations have a lower risk of ALS than other populations. Military service, I think, is really important to figure out why our veterans get ALS at a higher rate than non-veterans. Chronic inflammation is certainly very important. Oxidative stress, build up free radicals happens throughout our lives. Is that potentially linked to ALS or not? Gut microbiome, what you eat potentially could certainly influence inflammation in your body as well, and could that potentially lead to ALS, and so forth. And so these are just some of the areas we actually are funding and continue to fund. Next slide, please. And this is just some of the institutions we are funding or have funded in the past. Next slide, please. And so some of the important ALS findings I just want to kind of go over. Our own program actually has actually published over 100 papers on ALS, and they're all open access. You can actually come read them as well. And some of the stuff we've actually have found, such as head injuries, those occurring in early childhood and adulthood, actually increase the risk of ALS beyond the age of 60. So potentially having a head injury early potentially could be a risk factor for ALS later on in life. We're working with brain chemistry labs to see a potential blood test for using microRNA. So that certainly is really important. They've actually used our own data from the biorepository to kind of work on this particular diagnostic test. We also found that Black ALS patients who are Black with ALS, they actually have tend to be diagnosed at a younger age. So we're not sure exactly what's going on there. So we want to figure out why that disparity is. And we also found that particular population in the African American population experienced pneumonia more so than the white population as well. And then also we have our partners here, Dr. Stephen Goutman out of the University of Michigan. They've actually have published a number of studies looking at, for example, pesticides, lawn care products, and so forth. And if they're in your home, like for example, attached to your garage, are those potentially linked to ALS? And what they've actually found was a shorter ALS survival if you actually have this particular stuff in your home as well. So I would certainly encourage you to come to our website and see other publications. This is just a small snapshot of the publications we have. Next slide, please. And just right here is just kind of closing slide, the impact of the National ALS Registry. Like I mentioned, we are one of the largest ALS databases of ALS in the US, if not the world. We work with drug companies as well as academic institutions to kind of augment their studies and their clinical trials. Our biorepository is a free service for ALS patients. We fund research. And pretty much at the end, we want to figure out the who, the what, and the why of ALS. As an ALS researcher, like Dr. Heitzman, I think we're kind of biased here. We want to figure out, why ALS is occurring and have certainly viable therapeutics for ALS to kind of go ahead and mitigate and hopefully down the road prevent ALS. I think that certainly is everyone's goal, is to go ahead and prevent ALS down the road. It is a devastating disease. It's a diagnosis which is life-changing. And so at the end of the day, we are all in this together, whether it's the National ALS Registry or MDA or other ALS clinicians across the country. We all want the same thing. Thank you.
All right. Thank you, Paul. I'm going to speak here about the two MDA registries and then the future MDA registry assessing neuromuscular disease. So about 10 years ago, so now maybe a little bit more, the MDA recognized that there was a data shortage for neuromuscular diseases and stated that crafting strategic approaches to accelerate data collection and use by researchers, clinicians, and drug developers is important. One strategy was to create this MDA care center network, and it is comprised of 150 care centers, 2,400 clinical providers, and 90,000 medical visits over 60,000 individuals annually. The registries that were created by the MDA back in 2012 was initially the U.S. Neuromuscular Disease Registry. I'm sorry, next slide. So we created the Neuromuscular Disease Registry. Thereafter, we created the MOVER Registry, the Neuromuscular Observational Research Data Hub. And both of these were paper-based. The latter was halted earlier this year. In the future, there's going to be a new MOVER registry pilot program to begin later this year that is going to be AI-based. Again, as I mentioned before, that the prior two registries were emulating success, and at that time we were looking at the Cystic Fibrosis Foundation, and we're aware of Dr. Mehta's CDC National ALS Registry. So next slide. So the U.S. Neuromuscular Disease Registry looked at 4 diseases. There were 26 centers, and we collected data between 2013 and 2018. It was ALS, SMA, Becker, and Duchenne. Of the sites that contributed patient information, ALS had the highest representation. Then we created the MOVER registry, which included 7 diseases. And this was 54 sites, 150 care centers. And there's a map showing all the sites that were participating. Next slide. And this may be hard to read, but this is giving a timeline about how the registries are were created. If you look at on the left of this page at the bottom, we had 4 electronic case report forms, which included demographics, diagnosis information, treatment, and then the outcomes. The diseases that were added to the mover were Pompe, limb girdle, and Becker's. This is besides the ALS and SMA and Duchenne. Next slide. The Mover Data Hub incorporated the prior neuromuscular disease registry information. And this looked at the total, this is a slide showing the total number of patients that were enrolled, which was 73 sites. There were over 5,000 patients enrolled with almost 19,000 encounters. Again, the majority of the patients who were data collected was ALS. Next slide. This is just some of the example from every disease. We have data sets that will, depending on what you're interested in, be able to take information and say demographics, age, symptom onset, and medications. So here's one abbreviated slide regarding ALS. It talked about gender there at the bottom right and medications that were used to treat ALS. Next slide. Another disease, SMA, similar information can be collected. We're looking at the number of participants and then follow-up visits. And on the right, it was about tracking the adoption of therapies, and which was very variable over the disease. At that time, you could see Spinraza and the other medications were coming out, and now there are more. One thing that's important, and I'm being tangential here, is we now have gene therapy for some of these diseases like that are given one time. And there's an importance that we need to track the outcome, and including for the ASOs for treatment for ALS. We don't have 15 years of data, and we need to track these, and it's got to be available to the neuromuscular community and not just be proprietary. Next slide. ALS and the PLS natural history studies. I mentioned this PLS natural history study. PLS is a disorder ultra rare that a number will manifest into ALS. We participated, this trial has had 34 sites in the US and Canada. We'd like to determine why people convert from PLS to ALS. We've been collecting demographic and clinical data, biomarkers, and EMG with an intent to initiate the first drug trial for PLS. The PROACT database is pooled resource open access ALS clinical trials. It's pooled data from 30 phases, from phase 2 and 3 trials and 1 observational clinical trial. There's over 12,000 patients with more than 16 million longitudinally collected data points. It includes demographics, labs, family history, and other data elements. We're hoping to use this to speed up trials by looking at some of this data that we could tease out things that matter. Answer ALS, which has been a monumental project led by Jeff Rothstein at Johns Hopkins. It's a biological and clinical resource from which we collected patient-induced pluripotential stem cells and longitudinally collected data, biomarkers, smartphone data, over 1,000 patients. IBM Watson and Microsoft have assisted with the data analysis, and it's still going on today. There were 7 ALS centers who collected the data from 2016 to 2019. We have over, at this time, 250 trillion data points. It's still a work in progress, and the MDA is one of the sponsors. And the next slide, I'd like to talk about programs that are addressing ALS, but also other neurologic diseases. Act for ALS is a private-public partnership through the FDA, NIH, a bill that was signed in 2021. Over 100, it's over 100 million annually are being delegated over 5 years to foster drug therapy. So this includes the AMP for ALS data platform, which opened up last year. We're also doing expanded access programs through this government bill, which has been terrific for patients because most patients do not qualify for ALS drug trials. So we're giving these patients this essentially compassionate use with drugs that are currently being tested. As part of this bill, there were two programs created. One was called All ALS, the other is Prevent ALS. So we're collecting clinical information, blood and CSF samples longitudinally over 2 years, as well as speech samples. And most of these can be done at patient's home. The data is being sent to a central repository, at least the biomarkers in Indiana. The CDC National ALS Registries collaborating. We also have controls as part of the study. Likewise, there's the Prevent ALS. We know that patients with a family history of ALS are often concerned, am I going to develop ALS? We're now following these patients, collecting samples, clinical data, and spinal fluid analysis, and with an intent to possibly treat people pre-symptomatically. And then next slide.
Okay. Dr. Mehta, Dr. Heitzman, thank you so much for that wonderful coverage of some of the fantastic work you were both working on and getting some of our centralized data coming in for ALS and so many neuromuscular diseases. We've kind of touched on the importance of some of these centralized hubs to build data in, of course, the rare area of neuromuscular disease. And this is fantastic, but we still have a number of smaller registries focusing in on other specific disease processes. And Dr. Isford and I will cover a few of those to kind of give you a little bit of a flavor of that. And I'm going to focus just a bit on one of my areas of interest, which is myositis, which I think serves as almost a microcosm of neuromuscular disease and the involvement in registries. Next slide, please. A little bit wordy here, but most importantly, myositis is a little bit of a tricky disorder because it's not really a disorder. It's multiple diseases, including things like dermatomyositis, autoimmune necrotizing myositis, and antisynthetase syndrome, as well as the more unique degenerative process of inclusion body myositis. And so the types of registries and studies that are being done here illustrate some of the larger movements that have been already referred to in trying to kind of pull together the data in order to build our knowledge of both myositis and how to kind of move forward with it. MyoNet is a large multi-center registry effort that originated from a small group in Europe and has since kind of expanded into multiple centers across 16 countries. Institutions essentially apply to be a part of the registry and then place patient information both from clinical and serologic information into their database, which serves as a place where researchers can then sort of apply to view that data and use it for various projects and papers. And since its inception in the sort of mid-2000s, there have been a number of publications that have come out from that, in addition to collaborative projects that are being developed looking at different myositis patients, including the use of wearable devices and how that can inform us on the day-to-day function of these patients. On a slightly different token, the Yale Inclusion Body Myositis Registry has been a much more patient-focused event. This was actually the original brainchild of an economics professor at Yale, Martin Shubik, who was diagnosed with inclusion body myositis and sort of recognized that there was essentially a dearth of information out there on the patient experience. What should he be expecting in his day-to-day as he moves forward? And so in conjunction with the neuromuscular team at Yale, they set up the IBM registry to allow patients to essentially voluntarily provide their experience through questionnaires and placement of information in the database. And they've been able to create a number of questionnaires similar to the National ALS Registry to provide additional information on the overall patient experience that have been published over the last few years. They're still accepting patients into this registry and have the opportunity to provide additional questionnaires and hopefully build on our knowledge there. And one unique feature of the Yale IBM registry in their website is it provides the opportunity for patients to actually compare their experience to the general population of inclusion body myositis patients there. They have what's called the personalized index calculator that patients can take part in, inputting some of their information about their disease course, their symptomatology, and see how that compares to the overall population of the IBM registry and get a better sense of how things are comparing to the expected course, and maybe even prompt some additional discussions with their doctors. So this is something that I feel like IBM patients have really taken to in order to be able to see that sort of comparison. So it's an interesting one to have your patients involved in. Now, in contradistinction to these registries, I did want to mention one of the ongoing and sort of highly anticipated natural history studies, which is sort of more of that closed book type of research where we're bringing in patients and following them for a set period of time, collecting certain amounts of information, clinical, serological, and even collecting additional biomarker data in order to really see what's going on in these patients in a prospective manner. This was originally set up by some of the folks at UC Irvine, and they're continuing to kind of work on that. It's been going since about 2021, and they will finish their data collection in 2026. And so this natural history study that's a bit more prospective illustrates that these are definitely more in-depth dives into the data that they're gathering, but move a little bit more slowly than sometimes the registries can. And so that myositis component, definitely a good illustration of that. MyoNet being the institutional registry that can serve as a database for other researchers. The IBM registry at Yale, a little bit more patient-focused and voluntary in their input. And then the natural history study that is multi-center, Inspire IBM, that is sort of a set trial, gathering patients and following them for a set period of time before finishing that data collection and publishing later as a typical natural history study goes. And so these are just examples in the myositis space. And now I'll pass things off to Dr. Isfert to talk with you about the hereditary neuropathy space in CMT.
Yeah, thanks, Matt. And so I have, in my clinic, like many of our other neuromuscular diseases, get a lot of questions from patients with Charcot-Marie-Tooth and other inherited neuropathies about ways to get involved and opportunities to participate in research and registries. And so as part of that, I kind of put together some resources for patients. And there are multiple different registries for patients with CMT. And the goals, in these registries mirror a lot of what you've heard of from Dr. Heinzman at Burford, in that they are looking for clinical trial readiness, understanding the breadth of CMT symptoms in the patient experience, looking at common CMT varieties, as well as some of the more rare, ultra rare CMT varieties, and gathering data about some of those less common CMT types. Next slide. And you've heard, again, from the previous speakers about how impactful registries can be. And one additional example of this is, from the Italian CMT registry, which is part of the TREAT NMD Italian NMD registry. And they've had a very good CMT registry that has generated multiple publications over the past seven years. characterizing CMT in the Italian population, but also providing some insight into CMT throughout the world. And in addition, I think one thing to highlight from this registry is that it also allowed for large-scale evaluation of some less studied topics, including things like the use of ankle-foot orthotics in CMT, sleep disorders in CMT, pregnancy for patients with CMT, and neuropsychiatric comorbidities in CMT that require, or in their case required, a larger data set and more data points that the registry was able to provide. So this, just to mention, kind of a case in point, another case in point about how registries can be helpful. Next slide. And so a couple of the CMT registries I wanted to mention. The first one is through the CMT Association. It's the CMT Patients as Partners. And so this registry collects surveys about symptoms and experiences from patients with CMT. And they have a focus on all CMT types, but also includes some specific sub-projects, evaluating patients with less common CMT types. It also provides some opportunity for the patients and opportunities to participate in things like focus groups and discussions with biotech and pharma companies. And it also helps in enrolling patients in CMT Association funded research, as well as joining patients with other clinical trials throughout the country. Next slide. And this registry through the Rare Diseases Clinical Research Network is quite broad, but something that I found useful for a wide variety of neuromuscular diseases, including CMT. And so this registry collects and stores contact information for subjects who would be interested in participating in rare disease clinical research network sponsored trials, and to learn more about other research opportunities. It's NIH funded. It encompasses over 200 rare diseases, so it's not just CMT, but something that if you have patients with other rare neurologic conditions, that they may be able to find opportunities here. Currently, there's 4,000 participants, and it consists of over 20 different disease consortiums. For the CMT, this registry through this page is linked with the Inherited Neuropathies Consortium, and also has links to other neuromuscular diseases such as myasthenia gravis, leukodystrophy, and vasculitic diseases consortiums. Next slide. And the final one that I've found but have a little less experience with is the Global Registry for Inherited Neuropathies through the Hereditary Neuropathy Foundation. This is another registry that is out there. It's open to any patient with CMT. There's been some associated natural history studies with this, both in the adult and pediatric population. And they have over 6,000 participants associated with this registry. And so that was just an overview of some of the registries that are out there for CMT, and serve as a nice complement to some of the registries you've heard about, as well as the MOVER registry for some of our other neuromuscular disease patients.